Hey,
We are here. We are here. How are you?
I am great in yourself.
Cool, cool. How's your week been?
It was surprisingly it went by fast, and I'm really glad. And I
Good.
don't know how it happened, but I hope it's not too noticeable. But I have a cold sore.
Oh, sir. Uh-oh. You stressing out? Are they stressing you out on this job?
And I tell you, I never in my true story, I never in my life got a cold sore until I became a coder. When I was in trading, I was stressed out, and my lip was unsightly.
Oh no. Oh no. See, you stress relievers, you got to find a way to uh breathe through it or find a different hop something to relieve the stress, cuz yes, this can be a stressful profession. Folks don't understand that, but it can be. Especially when you
Yeah,
fighting tooth and nail for folks to get them to understand stuff that we already understand. Like what? What?
it all be so
Crazy.
simple.
It could all be so simple. Yes, sir. Yes, sir. Well, welcome to our Saturday morning tea where we discuss health information, news, education, certification tips, entrepreneurship, the stress that comes with the health information profession, and the revenue cycle at large. And as you come in, don't forget to hit the thumbs up or like button. I am Clarice Warner, the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. And PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance in education. And let me ask you, do you know what it takes to be a certified marketable medical coder? Do you? Do you really? Well, before I introduce my co host, let me share with you information on a free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. I be wanting to do that little dance that the kids do. um, if you are interested in getting more information about the 5 steps to become a certified marketable medical coder, yes, that free email course, then check out the link in the description box for the details. So, joining me today is my illustrious co host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Hello, everybody. My name is Jesse. I live in Philadelphia. I've been a nurse for more than 3 decades, and I transitioned into medical coding in 2014. During the pandemic in 2020, I created a company, the Coding Nurse LLC, where I help nurses and other healthcare professionals with clinical backgrounds transition into the wonderful world of HR.
And isn't it wonderful?
It is.
It is.
And it's,
We joking kid, but it is a wonderful world.
and
It's
it's
a
big.
wonderful world.
It is big, and there's a space for everybody.
everybody, everybody doing all of the things. So before we jump in, let me remind you that while we bring the information and the content, you can join in because this is a conversation. We want you to add to the conversation. So don't be shy. Your opinion matters and it's welcomed here. For Facebook, YouTube, and LinkedIn, please use the chat. If you have a question, place the Q first so that we know it is a question and we don't miss it. So, for those who are joining us or watching the replay today we are talking about autonomous coding. So, that will be the focus of our discussion. But I swear, I feel like all these church announcements is going to take over. I feel like that's where the jam is going to be. Let's get on into it. I don't even have a fan. I should have packed it. Yes. Yes. I needed a little bit of that today. I needed a little bit of that. All right, all right. Just the whole thing. That's just a whole vibe right there. That's just a whole
It
vibe.
is.
So, today in our church announcements, the first thing I have is the CPT is not even valid yet. It doesn't go into effect until January 1, and we already have some revisions, some deletions. We have some things going on with CPT. All of the stuff that we learned during COVID, all of it, every last one of them, going away. So, effective November 1st, all previously approved COVID-19 vaccine product and administration codes and the entire Appendix Q will be deleted from the CPT code set, with the exception of the Novavax vaccine product. I think that CPT code is 91304. That one will remain active as they are waiting for the approval of that company's updated vaccine, which is currently under FDA review. So you could just put a big old X through all of the the COVID-19 vaccines and administration codes because they're no longer valid. Period. The unfortunately the book was already published before this went into effect, so they weren't able to stop the printing and the press prior to, but you heard it here. Probably not first because this has been for a minute, but you've heard it here, and maybe it is the first time you're hearing it, but you heard it here. Those things are no longer valid, and that whole Appendix Q, just pull it out your book, because it doesn't exist. Mr. Jesse, did you have any comments on that?
No.
No, yeah, that was straightforward. The other thing is, a few days ago, the AAPC held their social hour on Facebook Live, and announced that there will be a change to the AAPC's magazine, the Healthcare Business Monthly. I believe this is probably the second or third change in of this publication since I've been around. Beginning with the January 2024 issue, it will now be called the AAPC, the magazine. So AAPC, the magazine, that's what it's going to be called. No longer will it be the Healthcare Business Monthly. The format, so the types of articles will be the same. So nothing is changing about that. There will be some style and color updates, and most of the changes are due to the American with Disability Act recommendations, making it easier to read and see. So that's where primarily the changes are coming from. But they rest assured said the format will be the same. You'll still be able to get the quizzes at the end to get CEUs. All of that will be similar to what you are used to if you are currently an AAPC member and receive your magazine either digitally or do they mail
Do they what?
them? Do they mail them still? I know they do them
I
digitally.
haven't, I
I
haven't
ain't got a
gotten
mailed
one.
one in years, so but they're changing it. So be on the lookout for that in January. Any comments on that one before I hit to the big time? The big time.
No, but I mean, I kind of like it. AAPC, the magazine.
Yeah, I mean, it's supposed it tells you immediately what it is. I felt like the healthcare business monthly kind of you didn't know it came from AAPC. You didn't know, what this was about. You didn't know that it was and while their tagline I think is the business of healthcare. I just thought it was too broad because anybody could tag into that. You have all these other organizations that could easily just pull that right up. So I feel like this now addresses their core membership and their core audience. So I think kudos to them on those changes. That was a good look. My
Definitely.
friends, I'm sorry, go ahead.
I said definitely.
Yeah. Whew. Okay, let me breathe. Let me take a breather. I need some tea, but I do have some water. So let me take a swig. It is water, nothing else. My friends over here. Oh, it's rubbed off a little bit at the AHIMA. Whew, okay. So I know most of y'all probably heard it first because I talked about it when we first got back from the House of Delegates and the conference. And then it was kind of like crickets. And then all of a sudden, the social media airwaves, these internet streets were on fire. I started hearing and seeing all kinds of commentary and information related to the announcement that was provided to the folks at the House of Delegates, as well as those who attended AHIMA 23 about CHIM and their proposed recertification requirement changes. That 40% of CEUs must now come from AHIMA starting January 2024. As soon as that hit, folks had questions, folks had concerns, folks wanted to have discussions, folks wanted to sit at the table, folks want to understand what in the world, where would you get this from and why? So letters from a component associations, from the House of Delegates, and from individual members voicing their concerns and displeasure with this proposed change have been sent to AHIMA for a while now. Well, you should have received an email from AHIMA yesterday stating that they are postponing this update to the recertification cycle starting in January 2025. So it's a little battle win, but not the war. The war is still going on. And while folks are okay with the postponement, they are still not okay. Letters are still forthcoming, and this issue isn't quite finished because if you read the email, it pretty much just says, yeah, we heard you. We've gotten the letters, this, that, and the third. We will postpone it in order for us to regroup, in order to package it better and provide the information to the members on what they need to do to get this 40% for recertification. So it's not off the table. It's not something, and the tone of the letter clearly indicated it's not off the table. They just want to make sure that folks have a better understanding. And so they're providing some additional education around what they are doing. And again, that is not just the gist of why folks are up in arms. However, if you would like to have your voice heard, let me encourage you to contact your component association president, or you can actually email me I have a letter. I have a template letter that you can customize and send to AHIMA. You can put your own spin on it. You can send it directly to them because remember, advocacy and members matters. Mr. Jesse, did you want to have any commentary on that?
I when I got the email yesterday,
Gift
I
of email.
was I was surprised but not shocked because I kind of figured that they were going to like you. This is this is a battle, but they didn't win the war. They got this battle. They just kicked the can down the road.
Mm-hmm.
And it really did need to be kicked down the road because next year is way too soon. And they just really, I hope that if they're trying to move forward or insisting on moving forward, they need to offer people something that they will want to spend their money on that's going to be worthwhile to meet the requirement.
Yep. And so you still have the conversation around so their thing was that these other offerings may not necessarily be as rigorous with the same quality and the same consistency as AHIMA's offerings. And so I think that one has clearly been slapped down by everybody because how you gonna feel that something that you're providing is of a certain caliber or quality if it's 8, 9, 10 years old? um and then you don't there's so many gaps that they're not providing education to specific groups. There's whole gaps of folks that there's nothing you're not offering them anything, but the expectation and the requirement is that they have to get 40% of their CEUs from this organization. And I get what AHIMA is trying to do. I understand it to some extent. The problem that I'm having, and I think a lot of our component associations are having, is in one breath, they want to say, we're one. AHIMA and the component associations, we are all one. But now you're splitting them. You're splitting the educational offerings that you can get from your state because they're not part of this 40%. So if you go to your state component annual meeting or any type of education that they provide, even if online, because I know at OHIMA, the Ohio Health Information Management Association, we have lots of virtual coding sessions. We have we got a whole library full of stuff, as I'm sure other state associations do as well. None of that would qualify for that 40%. It has to come directly from AHIMA. And our thing is, aren't we partners here? Aren't we part of the family? Aren't we a team? So
Right.
why not? And the thing is, one, your state association, in most cases, your state associations, the fees that for CEUs are much less. We've talked about a lot where there are several. We even had Brian on our show where there are several places that you can get free CEUs. Again, none of that, unless it comes directly from AHIMA, would be part of that 40%. And so where is the compassion, if you will, for your members, especially during this time? I mean, folks are losing their positions, folks are being laid off. It's a very still uncertain time, inflation, all of the things are happening. Yeah. And where was I? There was another oh, that was at AHIMA 23, I think, as well, where AHIMA has been hit with several losses due to their educational resources. So if you are an AHIMA approved or CTRIM approved institution, specifically school, there is a requirement of some sort or something that ties you to their resources. So they want to encourage the schools to use their books. Well, a lot of people are not going through the schools to get their education. A lot of people are just getting, certifications that don't necessarily have to tie to formal education. So they're missing the finances directed to that. But then you got to also take into account the quality of the materials that you are provided. Because if the quality is not there, why would I spend? And one of our board members said it so eloquently. She was like, these young folks, these millennial folks, they're not playing with their coins at all. And they'll
No.
let you know off top. We may have it, but you can't get it unless you're giving me something that I could use. And why would I spend $300 for a textbook that is 5 years old? That's antiquated at this point. None of the new things, the none of the new processes, AI ain't in it. Nothing is in it. Why would I spend the top dollar, $300? They want you to spend it. You couldn't sell that back to who? Nobody. So, that's where they made a lot of losses. But again, at some point, somebody has to take responsibility because you didn't put the same energy into making sure that your offerings were of a higher quality than most. So don't try to pass that buck off on the members.
Exactly.
That's not fair. That's not fair.
Me personally, like when it comes to resources, it's just like you said, it has to be of value. Because I mean, there's a whole separate conversation, but the price of books in college have been a sticking point for years,
I swear, I wish I
decades.
was in. I used to say that all the time when I had to put out the money. I'm in the wrong business. I swear, I'm in the wrong
Because
business.
it's nothing else. It is a monopoly,
Mm-hmm.
point blank.
Mm-hmm.
And people nowadays who are looking, especially these millennials, like you said, they're looking for value, and they will challenge something in a minute.
Mm-hmm.
I'm here for it
Mm-hmm.
because, like, even for me, like the only code books I have used for years and I will ever use is Optum 360. I have tried other books; it's just they just don't do it.
Mm-mm.
So
Ever since we went away from, and see, I'm about to date myself. Did you remember the channel? ICD 9 books where it was like a plastic kind of cover because you could use the book over and they would send you, and so instead of purchasing a whole new book, they would send you the pages that had to be replaced. So it would be a whole session for everybody to pull out their books and bring the packet of pages that they gave where you're now removing this one and putting this one in, and it was a whole exercise.
oh
Ever
wow,
since those books went away and they started making individual or allowing individual publishers, because CPT AMA is on lock. Nobody is, you can't fool with their money, they stuff at all. But they allow other publishers to publish the ICD set. I'm with you. Optum is by far to me the best choice. Even down to the quality of the paper and the print. There's some where you turn the page, the ink comes off on your finger. What is that? And then I know somebody's publisher, I want to say it's the ABC, but I'm not 100% sure. They were like, the page is so thin, you'll tear it just trying to turn the page. So yeah, I'm with you. I think by far Optum has a more superior product. Even in my courses, when I teach and I tell them what to get, I always recommend that those manuals. Oftentimes, even for the additional material that they provide in the book. So you
Yeah.
know the illustrations, the charts, the different things that can assist you and help you with medical terminology and anatomy and those types of things. Those books to me are superior by far.
They definitely are because, like, for my course, it's a required. Like, that's
Yeah.
the only book. And especially when people are learning, what I love most about it, it's just like you said, it's the quality of the paper. And I love the color coded tabular. I love all the color that's in the tabular. It's very easy to read. It
Mhm.
draws your attention to what it needs to be drawn to. And what I love most about the entire book is in the alphabetic index, they have those vertical lines.
Mhm.
Help you.
Yes.
It is so helpful when you're teaching somebody how to properly index. And then
Yes.
you start with on the first line, come down to blah blah. Between the two gray lines, then go to the second gray line. It's perfect.
Yes. Because they get lost in them indentations. Like,
Yeah.
well, wait a minute. Well, what does this mean? Yes, exactly. Um, Now I remember the one year, one of them books, the print was so small, Lord, everybody complained about that. I don't remember which manual it was. It was ICD. It was either the end of nine or first or second one in ICD 10. But the print was so. I mean, they had a whole revolt. Like, ma'am and sirs, we're getting older, not younger. We can't read 6-point font. Nobody can do that. Please make the font size a normal standard size that people can use or read. I know y'all trying to save trees. I get all of that, but y'all making money hand over foot because everybody got to have them. Even if you are on an electronic medical record, even if you're using an encoder, at some point there has to be a book somewhere in every organization, even if they're not religiously using them like we do.
Use mine every day.
All the time, all the time. Like, I get it. So yeah, those were the church announcements. Woo, yes, a lot was being held there.
And the books make a perfect segue into our topic.
Don't they though? Look at you. Look at you. I love it. I love it. Oh, but do you have a church announcement that you need to make today?
No. Okay.
Really? Oh my God.
I have a class starting on Monday, January 8th. The information is available at thecodingnurse.com.
Yes. See? Lord Jesus, I try. I swear I do. You can't say I didn't try.
That's
You can't
true.
say I didn't bring them to the water. Lord, I bring the water to them. I bring it to them. I make it ice cold and everything. Here you go. All right. So today, let's jump into the uh autonomous coding. So I was in a meeting. Um, it was our last meeting of this year. My state association, and one of the things that we do is we have a couple folks that are video savvy. I'm one of them. Anytime they ask me to put together a blog post, I'm like, I'm putting a video together, and they love it. And so we have another director on the board. Part of what she does is around, I believe it's around the revenue cycle. And so they would introduce or interview people or just let folks, put together um, less than 20-minute videos around a certain topic. So she told me that somebody did one on autonomous coding. I said, well, where is it? I need to see it. I want to know. And so I went out took a look at it, and I said, "Oh my God!" So we talked a little bit a couple weeks ago about AI and the impact of it on medical coding, and this gave me, and I believe I think she works at one of the autonomous coding vendors, I
Okay.
believe. So this gave me some additional insight. Okay, let me see if I can share this screen in this video. I don't want to play the video, but I want to show some of the screens that were there because I really want to focus on and take a look at the impact of the technology on our profession and some of the career opportunities. She actually had a full slide that talked about some career opportunities for us. Nothing, well, we've mentioned a few of them. There were a couple that I was like, oh, I didn't even think about that. Or from that perspective. So I do want to share that. And then somebody, I don't know if it was the comments to her video or something I saw where they no, it was a separate post. But somebody talked about they were new to the profession. They were in school. And they love it. They think it's a great profession. She's learning so much. She's excited about it, but she's hearing all the talk about one, folks not being able to find positions, folks not being able to find jobs, folks not being able to pass these certification exams. Should she go on and get her, I think she's in a HEMA approved school, so should she go ahead and get her RHIT or RHIA? And the elephant in the room about the AI taking over coding positions. And so the person said, I've been in this field for, I think she said she had been in the field for 20 years. And she said, I started back when it was on paper. And the first thing folks said to us, oh, the electronic medical record. When the electronic medical record comes, it's going to take over all of our jobs. She's like, I'm still working. And now we have AI. And she was like, and really in some aspects, AI is already here and doing some functions of medical coding, but we are all still here. And I agree with that. There's still going to always be a need for medical coding. It's not going anywhere at all. But I think even with the conversation for autonomous coding, it's clear on that. Someone mentioned in the comments that their organization has signed on to do some pilot testing of the software, and she was like, it's killing us because it's a hot mess. It's like it's bad. And I'm like, uh-oh, I don't know if it was her organization or not, but she was like, it's not what they're trying to build. I said, oh, that's not good. Okay, let me see how we could do this. I don't have my second monitor either. Okay, we're gonna make this work.
That's right.
I'm trusting and believing. Okay. So here is, I wonder, can I, wait a minute, let me see.
It's suggesting.
Okay, so yeah. So this is from Casey Garrett's. I hope I'm saying her name right. She's a revenue cycle RCM solutions lead with NIM Health. And I thought that was one of the vendors. I believe that's one of the vendors. Is that, now that I think about it, is that the vendor that the AAPC hooked up with?
I said, I don't know.
Oh, I remember somebody telling me that I don't know if it's, well, supposedly, word on the street, a HEMA hooked up with somebody or have an investment into um, an AI company, and I
Right.
heard AAPC did too. And
Uh,
this is the name is familiar. It's ringing. It'll come to me. It'll come to me. Okay, so here is where she talks about the evolution of medical coding, how we went from manual coding to in the 80s to 2010s, computer assisted coding, which a lot of folks are very familiar with and still using today, going into the autonomous medical coding. And she breaks down kind of what that looks like. It's using an OCR engine, the natural language processing, AI, and ML, which she mentions in the presentation. I can't think of it off the top of my head. I'll it's written in one of the other slides. Enable clinical terms extraction. And so autonomous coding solutions derive the diagnosis and procedures and E&M levels and HCPCS codes by understanding the narrative of the medical record. And then an audit will actually confirm the code for submission into billing systems, or it will send for manual review. And that's what that process looks like. She gave an example of kind of the natural learning processes similar. That's what GPT is today. um we're circling. Okay. Here are some of the coding technologies. Your human interaction, your integration and usage, the accuracy and what's going on with them now, code explanations, and time. So some things can be done within seconds, some things can be done within minutes. Um, so they're saying human interaction is exception based with EMR coding functionality. With the CAC technology, it's required for every chart. With autonomous coding, human interaction is not required. But I think there's, well, I'll wait till we get to another slide, because I believe she even goes back to say, yes, there is some human interaction. Not necessarily for that initial piece, but there's a workflow that she shows that it can go to either directly to the billing, or even in the last slide I showed, go to or for a manual review. Showing how the workflows, how they may change, or if workflow changes. It's even here. Integration and uses coders only need to review complex charts flagged by software. So for me, that does not mean that human interaction is not needed. Clearly, it says they are. Some of the accuracy, known for assigning non-specific codes and symptoms, is the EMR coding functionality. Known for suggesting inaccurate codes is the CAC solutions. I believe we even talked about that here.
mhm.
And then they're saying autonomous coding solution is accuracy consistently over 95%. Again, ask some of the folks that are using it and they may give you a different number. I think I've seen something as low as 70%. With code explanation, there's no natural language processing, pulling from orders, registration, or previous encounters, very specific rule sets. With CAC, no visibility into coding rationale. With autonomous, there's supposedly clear rationale and full transparency for every code assigned. So this is some of the information that she goes into, talking about, which one is this one? Oh, machine learning. That's what with ML. So here's some of the terminology and the definitions. Artificial intelligence, or AI, is the practice of utilizing machines to mimic human intelligence to perform tasks, solve problems, and autonomously achieve goals. AI is like the coach of the team who tells the players what to do and when to do it. AI is like the brain of the team, making decisions and giving orders. With machine learning, it's a type of artificial intelligence model that can learn from data patterns. So ML is like the players on the team who learn from their mistakes and improve over time. ML is like the muscles of the team getting stronger and more skilled as they practice and play. And then you have natural language processing. And this is a way of enabling computers to understand, interpret, and generate human language in a meaningful way. NLP is like the communication between the players on the team who use words and signals to pass the ball and work together. NLP is like the language of the team, helping the players understand each other and work together better. So there is some definitions and examples. This was like the workflow that I had mentioned before. So you start off with the EHR. Charts are sent to the engine. Charts are instantly coded by the engine. Again, this is with autonomous coding workflows. Codes sent to billing, and then non-coded charts could also be sent to billing. There was another one I think she had that showed something going off to the side. These are reasons for dropped charts. 5 to 10% of the charts cannot be coded due to engine understanding gaps. 10 to 15% of the charts cannot be coded due to conflict in documentation. 10 to 15% of charts cannot be coded due to low confidence in one code on the chart. 10 to 15% of charts cannot be coded due to missing documentation. And then these were some examples of the reasons of the drop charts that they have seen or are seeing and where they're seeing them. Mr. Jesse, you can jump in at any time.
Okay.
Here were some benefits and limitations. Limitations of autonomous coding currently only covers certain specialties, primarily in outpatient. It's not 100% solution, only codes a certain percentage of charts. Machine learning based autonomous coding often requires less than a year of data to learn and lacks explainability. Lowered risk of staffing challenges, for example, finding experienced coders, attrition, and retirement. These are the benefit of autonomous coding. Enhanced accuracy, consistency, and compliance due to configuring one machine versus training multiple coders. The reduced risk of claims denial and delays in reimbursement. Improve quality of healthcare data through capturing additional codes, and increase efficiency through reduced time and effort required to manually code medical records. For example, 10,000 charts coded in a day. Bless y'all whole hearts. The productivity, boy, Lord. So with onboarding, with autonomous medical coding, you got training and configuration, validation and auditing, and evaluate and performance improvement pieces related to that. It was something else I wanted to show. This is the potential of where this could work. Ancillary outpatient services, outpatient service lines, and in inpatient. And this was HCC, other emerging potential use cases. They're looking at using this for HCC coding capture, quality audits, and charge reconciliation. Steps for success. So, evaluating your current coding challenges, seeing whether or not the organization has the technical infrastructure and expertise to implement, and the coding philosophy, documenting your organization's coding philosophy and guidelines, compliant with coding regulations. And here was the careers, the ones I was looking for. Okay. So in health systems, it says certified professional coders, coding auditors, billing auditors, denial coding analysts, quality assurance coders, and coding analysts. On the vendor side, and I think this is the part that we didn't, at least I didn't consider, pretty much, actually working with or developing products. Again, coding auditors, quality assurance coders, subject matter experts for the product sales, and compliance auditors. So that was pretty much all of the information. I don't think there was anything. And then this is for AHEMA. So if you wanted to get more information on health information, careers, and revenue cycle, OHEMA provides some information there. So yeah.
I just wonder. There's no way you can submit a claim. Well, no, no, no. Let me not say that. You can submit a claim any way you want, but I just
Hey,
think that
Marcia.
when they implement this, when they try to implement this, they're going to be hit with so many denials and or a serious loss of revenue. Because while I understand the intention of it, I just do not don't think I just don't think that programming is there yet. I just don't think the artificial intelligence is there yet because when it comes to coding, there are so many nuances. And I know like we had computer assisted codes before what happened, but it does it are you really happy sending out unspecified codes? Like they'll say, um, uh, cellulitis of lower extremity, but when you read the chart, it's very clear that they said it's the right leg. Those are two separate codes.
Mm-hmm.
So
And
it's just
if you how could you possibly, I mean, part of the overarching overhaul of ICD-9 to ICD-10 was for specificity purposes so that you could have those um right and left finger, 2, 3, 4, whatever, you can have the specifics to those codes. And even as ICD-11 is on the horizon, again, you have that's another piece that has to be factored in, and how that's even further bringing an additional level of specificity to diagnosis coding.
right.
And we say it all the time. Hell, if it was easy, everybody could do it. Everybody, including machines, if it was easy.
That's right. I just don't know. And I can see it in the outpatient in some settings, but I just don't know how you can have that level of complexity in the inpatient because you can have in certain situations you can pick whichever DRG you want based whichever one will give you the most revenue. Is this technology going to be able to make that level of decision making?
Right. And find the support for it and validate it.
Right.
I don't think so. And again, and maybe it's the cursory review that maybe it would be able to say, okay, this is similar to what they already do now. Like if you use an encoder, here are some additional things that we would recommend or want you to take a look at. So maybe they provide that cursory, hey, these are some things that we think or that could potentially be there. But ultimately, somebody needs to validate and make the decision on whether or not it is there, which could ultimately alter that
And
MSCRG.
and I think that there are two other things that I think that for number one, my first point is I think that people who are new to HIM, they should have less fear of AI and more of an issue with outsourcing because that's their biggest issue right now. It's not AI.
Mm.
And I had another point. It'll come back to me. But they really need to focus on why is it acceptable for companies to outsource jobs to third world countries? Let's just call it what it is. And but yet and still there's a level of expectation, a level of excellence that they expect domestically.
Mm. Because they'll give them a pass all day because they only paid them $1. But
Exactly.
because they paid you 20, uh they're holding you to a different level of a different standard.
Right. Because I think that's the biggest threat to the industry because there should be, like I've said it for years, like the process to get a job in medical coding after certification is ridiculous because these certifications are not easy. You have to put a lot of time, effort, and energy into learning, into preparing, and successfully passing these exams.
You're right.
And why in the world would you go through all that and then lose a job to somebody 5,000 miles away?
You're right. You're right. You're absolutely correct. That is that's more of the current um challenge and what folks are feeling in these positions now that they're outsourcing or offshoring to um these organizations. And I think um I know there's the Facebook group that is geared primarily to supporting the American medical coder. Um, and they're very vocal over there. Very, very vocal over there about what's actually happening with these organizations and offshoring. And it's really sad. And to your point, it's not. And maybe at some point down the line, maybe that's the other thought. Well, if we could slowly get this offshoring, which because you're gonna pay more, you're gonna still pay more money, um, adding the technology because technology ain't free at all,
True.
at all. And so, while you may get to her presentation 10,000 charts a day, how many of them are valid or billable and at what's the price point or reimbursement for them, and then how many other people still have to be involved with them. So whereas you could have one person who could provide you the everything on the front end and possibly back end, you got 3 4, you got somebody to have to update and support and do all the things with this engine where you only have the one person on the one end. I don't know. It seems like it's more.
It doesn't make sense to me to call yourself eliminating one job, but you create 17 on the back end.
So where is the savings? Where's
Exactly.
the ROI? Where's the
Exactly.
I don't get it. I don't get it. I don't get it. And it feels like an attack.
Right.
An attack. So you're right. I think I want to say, hey, Renita. She said she had oral surgery, but I'm gonna pull up. Well, thanks for pulling up. How you doing? um, yeah, I don't know. It's just more things to come on this. We will definitely keep you all abreast of what is happening in our profession as it relates to this, because um while they have been talking about it, and people have been working. I mean, look at it at chat the AI. And
Right.
while some people are just now hearing about it, well, it didn't just start yesterday. It's been in the making for a while, and I think some of this we're seeing some end result of some of the things that have been in the making. But I don't think it's ready. I don't think
Right.
it's not here. It's not
No,
here. Not yet. It'll be a while.
definitely.
And even when it comes, there still will be opportunities for human interaction and medical coders.
Absolutely.
I stand 10 toes down on that.
That's right. You know, I got to go pick up a delivery at the door.
Okay, well,
I'll be back.
we're about to sign off. So thank you all again for joining the Saturday morning tea or checking out the replay. Let me just ask, was the tea spilled today? I believe it was. I believe it was. If this information was valuable for you or valuable to you or for you, help us by sharing the video and subscribing to the channel. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you are either coming in or leaving out, don't forget to hit the thumbs up or like button. And also check out the Coding Nurses channel on YouTube. We will transition over into the meeting after the meeting. For all of our Patreons, we love you. Thank you for being part of the community. If you want more information and want to get some of the key things that we provide over there in our Patreon, check out the information in the description box on how you too can be one of our supporters for all of the work that we do. Mr. Jesse, did you have any final thoughts at all as we close up this session and move over to the meeting after the meeting?
As always, the tea was spilled, and I thank you for creating this space. And I hope everybody gets something out of it because
Yes,
we really bring
definitely.
value.
Well, I appreciate that. It was the part one of my. It's a passion. I want to make sure that folks are prepared. You have the tools that you need you to be a certified marketable medical
That's
coder,
right.
or in any other of the health information careers that you may choose.
Yeah.
All right. Well, thank you again for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care.